topic, not the topic, recalls. So, perichondritis picture was given, asked for diagnosis. So I got the question from the eMedici. Let's do it. Then we will discuss. Okay. So 27-year-old woman present to the emergency department. So, sorry, 27-year-old woman present to the GP practice clinic with the left ear pain and swelling. 3 days after being hit on the ear. This was an accidental injury. She has no significant medical history and take no regular medications. On examination, she appears well with vital signs within normal limits. The left ear is shown. Okay, so you all can see the erythema and the swelling, right, in this area. So, in the question, which one of the following is most likely to diagnose cellulitis, perichondritis, otitis externa, auricular hematoma, relapse in polychondritis? So, this question, we all can see it's a perichondritis, and because due to a small injury to ear, right? So, swelling and ear pain and the redness. Okay, let's discuss how these things appear. The most likely diagnosis in this case, perichondritis. Perichondritis is an infection of the cartilage of the external ear. Okay, chondrium means cartilage, right? Often occurring after trauma, ear piercing, or other injuries to pinna. The presentation of erythema, swelling, and tenderness of the pinna is characteristic of perichondritis. So please remember clinical symptoms. Okay, how these things are happen. Okay, so yeah, so this is the area of pinna, right? Okay, yeah. So please remember this picture. This is from eMedici. So how cellulitis occur? I think this is the same question. How the cellulitis occur? Cellulitis of the ear would typically involve the entire ear and would not be limited to the cartilage portion. So, if it is cellulitis, it's present like this, and also tend to have more diffuse appearance and may extend beyond the ear itself. Okay. And the otitis externa or swimmer's ear is an infection of the external auditory canal. While it can cause the ear pain and swelling, the primary symptoms are typically located in the ear canal rather than the pinna itself. Okay? So, auricular hematoma occur when blood collect between the cartilage and perichondrium of the ear, often due to the blunt trauma. So, auricular hematoma, how it's present, let's check. You have to here. This is how auricular hematoma can present, like bulging due to the accumulation of blood. So just remember, okay? Yeah. And the relapse in polychondritis is an autoimmune condition that causes recurrent inflammation of the cartilage structure, including ear. However, it typically affects both ears and associated with the other systemic symptoms. Okay, making it less likely. So remember, if it is relapsing polychondritis, it can affect the both ears with other systemic symptoms. So in our case, we can easily diagnose it as perichondritis. Please remember this picture. Okay. Yeah. And how we should treat these patients. The same scenario. And they have asked about the most appropriate next management. So the same thing, doctors, the same question. And the same question, same scenario. That's why I haven't add. And they ask about the most likely to diagnose, and here they have asked about the what is most appropriate next step. In that case, please remember, okay, please remember, if you don't have any perichondritis note, please after receiving this file, please make sure you have highlight and add these points, okay. So remember the oral ciprofloxacin Y. The patient presented with classical signs of pericarditis and infection of the cartilage of the outer ear, likely triggered by recurrent blunt trauma. A key distinguished feature is sparing of the ear hole, which help to differentiate pericarditis from cellulitis. Since the ear lobe lack of cartilage, pericarditis primarily affect the cartilage containing structures. Same thing, the most appropriate initial management is oral ciprofloxacin, which provide the coverage against Pseudomonas aeruginosa and Staphylococcus aureus, the most common causative organism. Prompt antibiotic treatment crucial to prevent the cartilage necrosis and subsequent ear deformity. In more severe cases, or if the patient is systemically unwell, broad spectrum antibiotic or intravenous antibiotic may be necessary. However, for this patient who appears well, oral ciprofloxacin is appropriate. So, you learn so much points: pericarditis symptoms, how to differentiate from other diseases like cellulitis, and you know what is the most common causative organisms, the two types, and what is the treatment of choice, right? Yeah, please remember that. The next question is single episode of postcoital bleed in postmenopausal woman likely diagnosed. And we got like same question from two recallers. Next one is menopause last 5 years ago. Single episodes of postcoital bleeding, had a recent sexual partner. This is first time intercourse in the last 4 years. So what do you think? Type your answers in the chat. Then we will discuss. So type your answers. It's okay. This is a recall. It's okay. Just like how you think about it. Yeah. Okay. What about other doctors? Yeah. Why you suggest this as a vaginal atrophy? Give me some reason. Mm. What about other doctors? Okay, so let's discuss. Yeah, only single episodes of postcoital bleeding. Single. Okay, that's also a key point. Single, only once. And postmenopausal. So what is in the chat? Postmenopausal. Yeah, postmenopausal. And the question is not completed. It's a recall. So we, in the real question, I think patient had more symptoms. So, okay, this is the first time, and first time after 4 years. Okay, menopausal last 5 years ago. And this is a postmenopausal woman, likes the same question, I think. And um, okay, so let's discuss about vaginal atrophy and why not others. Okay, yeah. Here, okay, so what symptoms occur with change in vaginal health? So, irritation, burning, itching. This is for postmenopausal women. Okay, I got it from one of Australian guideline. Haven't added the link because I have a screenshot and added it. So, irritation, burning, itching, change in no other discomfort, dryness due to decreased vaginal secretion, which may also mean sexual intercourse become uncomfortable or painful, because postmenopausal mean there's a lack of hormones, right? In that case, Due to that, there's a dryness. Because of dryness, it can cause postcoital pain and the bleeding as well. Okay. So light bleeding because the vagina may injure more easily. Any vaginal bleeding need to be investigated. We all know that inflammation as part of GSM, which can lead to the pain on urination and infection, persistent malodorous discharges caused by increased vaginal alkalinity. This may be mistaken for the thrush. Okay. This patient can have the vaginal candida. So management recommendation to minimize vaginal irritation: wear cotton underwear and change underwear daily. Okay, these you can read it. Okay, I'll explain what are the other main things you can use in this case. Okay, here the vaginal estrogen in its various form has been reported as effective in relieving symptom in this case. Okay, vaginal estrogen may cause mastalgia and vaginal bleeding. Any postmenopausal vaginal bleeding require investigation. Vaginal estrogen is effective only while it's being used. In some cases, it may be preferred to start at the reduced dose in order to minimize the irritation. So, please remember the vaginal estrogen, usually we can give for these patients. Okay, and the postmenopausal women, we can think about the systemic hormonal therapy, right? That's another topic. I hope you all remember that flow chart. Okay, flow chart. We need to remember that one. So like how we should add the progesterone and estrogen cyclically or not, like that. Do you remember that chart? You have to remember that chart for postmenopausal hormonal therapy. That's a different topic. But in this case, you can read it from here. This is from Australian, but I can't remember this thing. The guideline is from Australian. So, all agreed with vaginal atrophy, right? And let's see why not others. So, how cervical cancers present? Yes, cervical cancers, there's a bleeding between periods, so after sex, pain during sex, longer, heavier period than usual, unusual discharge, bleeding after menopause. Okay, so bleeding after menopause. So, 1 minute, doctor. I have to. I'm getting all the messages from my Telegram. Do not. Okay. One- yeah, now fine. Because I'm getting so much questions and asking about so much things. This is how cervical cancer is present. Okay, I have just added for your references. So, how uterine cancers present: bloody or watery discharge that might smell bad, discomfort or pain in the abdomen, difficult or pain when peeing, pain during sex, bleeding between periods or after menopause. So our patient has only one episode, right? Because our patient is after postmenopausal. Here they have mentioned 5 years ago, and she's not taking any drug. She's not taking any hormonal therapy or anything. So in that case, it can be due to the dryness, right? So the same thing. Yeah, so what is the cervical ectropy and how it present? You have to remember this. These are the key points for the cervical ectropy. It is being it is cervical ectropy mean benign eversion of the endocervical columnar epithelium. Ectropy. I'll show the picture. Okay, this is what happened in cervical ectropy. Here you can see, right? The cervical ectropia. Sometimes they can ask from this kind of picture, the real picture. Yeah, this is the ectropia, right? Yeah. Okay, so let's go back to her. Just give me 1 minute. I don't know how to, like, I have just mute my computer, but still getting the Telegram messages. Give me 1 minute. I'll figure it out. Okay. Okay. So let's discuss. Okay. So it's a eversion of the endocervical columnar epithelial into ectocervix. So in the cervix there are two types, right? Endocervix, ectocervix. In ectocervix, they say squamous columnar epithelium and endocervix. There is, I don't know, doctor. Someone know how to like mute these things because still I'm getting notification. I don't know. I know it's very hard to concentrate, you everyone. This I don't know. I have to wait for my husband. Close the app from the arrow. This one. Okay, done. Thank you so much, doctor. Yeah, yeah, I did think. Okay, so yeah, this is associated with the high estrogen state, usually adults in pregnancy and the women who use OCP, oral contraceptives. Okay, so this is associated with high estrogen level, common in young reproductive age women. So anyway, this is out because our patient is a postmenopausal woman. Caused postcoital bleeding and increased vaginal discharge, not pre-malignant and does not increase cancer. Its management is usually reassurance, treat only if symptomatic. And you have to remember one more thing, this is very high yield. Okay, so investigations in our question, they haven't asked about investigation, but this is a high yield part for the abnormal vaginal bleeding. So here the woman and people with a cervix with abnormal vaginal bleeding. Okay, so in our case, our patient is postmenopausal, right? Bleeding, postmenopausal bleeding. So we have to do the core test, HPV and LBC, right? And even persistent unexplained intermenstrual bleeding, in that case also we have to do the core test and refer for gynecological assessment regardless of the test result. But our patient is Our patient doesn't have postmenopausal bleeding. Our patient has a postcoital bleeding, right? This is something else, but usually they are asking from this part as well. And this is the postcoital part. So, postcoital bleeding also consider sexual health history and perform appropriate test. And the postcoital bleeding also, they have to do the core test, HPV and LBC. If the HPV not detected, then negative LBC. In that case, single episodes of PBC, and you don't have to remember these things, just remember about this cortex. Okay, usually they are asking about cortex, and then after we have to refer for the gynecological assessment. Okay, because here HPV detected, or in this case, even though HPV result is pending, we have to refer for the gynecologist. Okay, yeah, and the recurrent case also the same. Just give it a read. This is not the topic, I know, but give it a read, okay? So, next one is olecranon fracture X-ray was given. Digital numbness. Reason asked which nerve compressed. Type your answers in the chat. What do you think? It's ulna or radial? What about other doctors? But other doctors? Please type your answers in the chat. No one judging. So you can just answer. If you don't know it, it is still fine. You can just answer. You can just think and say. Yeah. Okay, so let's check the answer. Okay. So here there's the olecranon. Here you can see the like hook-like thing, right? This is the olecranon, right? Yeah. Okay, so this is the olecranon. Let's check. In here, when this is from RCH guideline, okay? This is how olecranon fracture can appear in the uh, X-ray. Okay, so here, please remember this picture. This is from RCH guideline. The isolated olecranon fracture typically transfers and involve the elbow joint. This is how it appears. Here, the olecranon fracture is associated injury. The same thing associated with the radial head subluxation with dislocation. Here, you all can see here is the fracture like that. Okay. So please remember this one. Okay. This is very high. So in this case, so olecranon fracture, please remember the nerve damage is ulnar nerve. I'll show ulnar nerve. Here you all can see how ulnar nerve is going, right? If the fracture is here, so what nerve is damaged? It is ulnar nerve, right? Right? You all agree with me, right? The ulnar nerve due to this olecranon fracture because it's going like this, right? Yeah, here, the more clear picture. The ulnar nerve is going. Here you can see how ulnar nerve is going from the olecranon area. Okay, so yeah, it is ulnar nerve. So, olecranon fracture, ulnar nerve damage can be seen. In here, little finger, ulnar half of the ringed finger, sensory loss can be seen. And another thing, motor deficits, weak fingers, abduction, adduction. Those are the things you have to remember. And what is the specific name when there's a ulnar nerve damage? What's the type of hand we can see when there's a ulnar nerve damage? What do we call it? Yeah, it's claw hand, right? I'll show. Yeah, this is the claw hand. Okay. Yeah, ulnar claw hand. Yeah. So you have to remember, okay? Here, the same thing. Please remember these pictures and how it's appear because usually in the exam they can ask, okay? Okay, I'll add this image as well. It would be easy to identify, right? Yeah, here, how it appear. Okay, so this is you have to remember these things. Then when we can see the ape hand, I'm just asking, okay? Where we can see the ape hand. Please tell me your answer. Here's a claw hand. This is the ape hand. Which nerve damage we can see the ape hand? Yeah, it's a median nerve. Please remember, okay? The claw hand, ape hand, we call this is hand of benediction as well, okay? Ape hand. So ape hand due to the median nerve damage. When we can see the wrist drop where we can see it's due to the radial nerve injury, wrist drop. Okay, please remember this is a good picture. Yeah, I'll add this one as well. Please, you have to remember these nerve damages. Okay, yeah, you can just read more about these things from the RCH guideline. Okay, I have added the link. Okay, let's discuss about other things simply as well. So you everyone know about. So what happened in ulnar nerve? What kind of sign we can see in claw hand? So when median nerve damage, we can see hand of benediction. No, we call it ape hand. And the radial nerves damage, we can see the wrist drop. Okay, wrist drop. And we call it Saturday night palsy as well. So please remember these things. Okay. Yeah, and you have to remember one more thing. We are done with olecranon fracture. Then what happened in the medial epicondyle fracture? Please remember medial epicondyle fracture also we can see the ulnar nerve damage. And what about suprachondral fracture? Suprachondral fracture. What branch of median nerve is affected in supracondylar fracture? You have to answer me. So, what branch of median nerve that affect in supracondyle fracture? What is a branch? Yeah, it's anterior interosseous branch. Okay. Please remember, usually supracondyle fracture can see in children. Okay. Please do that nerve injury questions. Then you will like never forget. Okay. So usually remember these are the key words. Supracondyle fracture usually in the children. So that means median nerve damage. The nerve branch is anterior interosseous. Okay, that is happening. Yeah, in here. And you can remember mid shaft humerus fracture due to due to this fracture, radial nerve damage can be seen. And the distal radial fracture, we all know at the wrist area. So medial nerve damage, the cause fracture. Okay. Yeah, can remember like that. And the carpal tunnel syndrome, median nerve, please like take a pen, not now, like after, write ulnar nerve and write down, make some arrows and like olecranon fracture, medial epicondyle fracture, like that. Then median nerve, distal radial, and the carpal tunnel syndrome, and like that. Then medial nerve, anterior interosseous branch, supracondyle fracture, usually in children. Okay, like that you have to write. Okay. Yeah, so simply olecranon, medial epicondyle, ulnar nerve damage due to this fracture, midshaft humerus, radial nerve damage, supracondyle, especially in children, medial nerve, anterior interosseous branch. Okay, the same thing I mentioned. So distal radius wrist carpal tunnel syndrome, median nerve damage. So at least remember this simply part as well. Okay, like that. So hope you all understand. So just who can summarize what are the fractures and areas affected? It's okay. It's okay. Okay, okay. No one is here. You know, one is willing to summarize. It's fine. No one. But you should be like talk with me, right? You have to be actively contributed, right? Okay, so it's fine. So let's discuss about next question. Just remember the types of hand, the drop hand, the claw hand, the ape hand, and the nerve damage. And you have to remember the fractures and the nerve damages. Please remember these things. Make a short note or summary and make appear in anywhere that you can every day you can see those things. Otherwise, it's gonna be forget. Because the nerve injury part you need to clear memorize. Yeah. So the next one is battered child case. 18-year-old mother said child fell from table, but child had bruises here and there. What will you do? So we only got bone scan. So there's a good article in RCH guideline about child abuse. Okay, I'll show this one. Okay, so when we are suspecting child abuse, okay, when we are suspecting child abuse, like when bruising from the investigation for occult fracture. So in that case, a skeletal survey is necessary in children less than 24 months old. With bruising of any of following features are present: history of confessed abuse, history of bruising occurring during domestic violence, additional injury on physical examination like burns, whip marks, then pattern bruising like more than four bruises, not limited to bony prominence, ear, neck, torso, buttock, genital region, hand, feet if there is no history of trauma. Okay, so a skilled survey is also necessary in child less than 12 months old with bruising in the following location: cheeks, eye area, ear, neck, upper arms or legs, hand, feet, torso, buttock, genital region, more than one bruise, not limited to bony prominence. So, what is a skeletal survey? What is a skeletal survey? Who can tell me what is it? It is a systematic series of plain X-ray of the entire skeleton, done to look for occult blood fractures, sorry, not blood, occult fractures, especially in suspected child abuse, to detect old and new fractures that are not clinically obvious, identify injuries of different ages, which strongly suggests non accidental injury. So, when it is done, when suspected battered child, non-accidental injuries, unexplained bruises, or inconsistent history, especially important in infant and young children. So in our case, 18 years old mother also 18-year-old mother, battered child killed. So in that case, we can suspect child abuse and we can do the skeletal survey. I got this question and this question had the skeletal survey as option. Okay. So please remember this algorithm. You can read furthermore from this RCH. Okay. So next move to our next question. 2 days after small cell cancer diagnosis, patient is teary and depressed. What to do? Supportive therapy, acceptance and maintenance therapy, CBT. Type your answers. Type your answers in the chat. Okay. Supportive therapy, acceptance and maintenance, CBT. What do you think? Okay, we got every answers right. Okay, let's check. So, and we got another question. We didn't get in the same like the same file. So I have gathered all in the same question is same. Okay, so next we will discuss this question, like more informative one. Okay, so 17-year-old man, 2 days, okay, here the 2 days diagnosed after a small cell cancer and admitted in hospital. Patient was teary and depressed. He has a good family support. Then what we should do, supportive therapy, acceptance and maintenance therapy, to start medication, CBT. So what do you think? What do you think, doctors? The same answer or not? Mm-hmm. What about other doctors? What do you think? Okay, so yeah, this is two types of question. Okay, so what is supportive therapy? So what is supportive therapy? Who can tell me what is supportive therapy? Okay, so let's discuss about supportive therapy. 2 days ago, after a diagnosis of small cell cancer, feeling tearful and low is most consistent with the acute adjustment reaction. At this early stage, the priority is emotional support, right? Not structured psychotherapy. Sympathy, yeah. So, why supportive therapy? So, normal response to a major life changing diagnosis. So, our patient is diagnosed with the cancer, right? It's a life major change in therapy. Focus on listening, empathy, reassurance, and practical support. So, first of all, if they're asking about the initial support as a doctor, like this is 2 days, right? 2 days, just diagnosed. In that case, first we have to listen the patient. and show the empathy and reassurance and practical support, right? Because that helps the patients to process the shock and fear. Appropriate first line approach in acute phase, right? So are you agreeing with it? The supportive therapy. Because it's just 2 days, right? 2 days and the small cell cancer diagnosis and teary and depressed. What to do? As a doctor, what we should do? We have to support the patient, right? First, we have to talk with the patient, right? Because it's 2 days, right? It's very early. What do you think? What do you think, doctors? Let's check. Yeah. What is acceptance and maintenance? Yeah, yeah, doctor. Yeah, in the first we have to be empathy, right? We have to show the empathy and reassure on the patient, right? Then after that, after consoling the patient, then we have to encourage patient, like encourage the patient to accept it, right? First of all, we have to listen the patient because patient is tearful, right? Here, patient is teary, and even though he has a good family support, always with the patient with the cancer, he always like mainly like focusing from some sympathy from the doctor, right? As a first thing. So because family support like emotional and everything, they have no idea about the treatments and they have no idea about the disease and everything, right? So because in that case, main thing the patient is always trusting the doctor, right? In that case, as the main person in this scenario, we have to listen the patient. We have to like reassure the patient like that, right? Yeah, that's the thing. This is like 2 days, right? That's the make sense. That's the yeah. If it is like more than 1 to 2, 3 months, then we can think about like psychotherapy or other things. Otherwise, it's like very, very early, right? We just diagnosed and patient is tearful, right? In that case, we have to listen the patient. We have to support him, right? Yeah. Okay. So next question. This question without having heavy bleeding and refusing for pelvic exam because she is currently menstruating, ask for the next appropriate management. We don't know what's the scenario, just question without having heavy bleeding and refuse pelvis. I think the patient is come for some pelvic examination and we can't patient we don't know the scenario, we don't know the disease, so we don't know anything about symptoms or anything. But according to this scenario, just like we need to do the pelvic exam, okay? We don't know the stem, but we need to do the pelvic exam. But patient is refusing due to the menstruating. So in that case, what we can do, TVS, hysteroscopy, this is transvaginal ultrasound, so speculum examination. So what do you think? Yeah, in that case, if the patient is not agreeing with pelvic exam, so we can't do it, right? It's patient's autonomy. We have to respect it. Right? So in that case, we can't do speculum exam. What about hysteroscopy? So it's not an initial thing, right? It's like a treatment or like very very invasive, right? So in that case, we can like easily do the transvaginal ultrasound. Like if still patient is menstruating and there's no harm, so we can go with TVS. Same thing I have mentioned. The patient does not have heavy bleeding and currently menstruating. Yeah. So menstruating. And she refused the pelvic examination. In this situation, next most appropriate is non-invasive test that does not require pelvic or speculum examination. So, first line investigation for abdominal uterine bleeding when pelvic exam not possible, non-invasive and acceptable during menstruation is the ultrasound, right? Speculum examination refused by the patient and not appropriate to force. We should respect her wish, right? We know. And hysteroscopy, not the first line, done after imaging and bleeding persistent, and as a treatment, we can go with that. That's like very late, right? Yeah. So we all agreed. Yeah. So next question. 27-week pregnant had sudden lower abdominal pain for 12 hours. She has upper respiratory tract infection and a cough. Pain gets worse on coughing. Diagnosis. What do you think? So, what do you think? Type your answers in the chat. These are the keywords I have highlighted. What do you think? Mhm. Let's check the chat. Brown ligament. Okay. What do you think about the rectus sheath hematoma? Is it possible or not? Mhm. Yeah. And our patient is having respiratory tract infection and cough, right? Patient is persistently cough and patient get worse on coughing. And why you don't think about rectus sheath hematoma? Because in the stem they have more towards to the rectus sheath hematoma, right? What do you think? I know these questions are tricky. What do you think? Let's discuss one by one. Mm-hmm. Yeah, that's what I'm telling. Here I have like hi, I have highlighted the key points. Here they have mainly pain gets worse on coughing, sudden low abdominal pain for 12 hours. She has upper respiratory tract infection and cough. Even this is like rectus sheath hematoma, right? Okay, so I have just added for some question. It's not a pregnant lady. Okay, I just add for to understand the theory. Okay, let's little bit discuss about the rectus sheath hematoma. So, what is rectus sheath hematoma? What is rectus sheath hematoma? Okay, so I'll show the rectus sheath hematoma. Here, you can see, right? The rectus sheath hematoma present like this. You should know the CT, okay? Rectus sheath hematoma present like this. And with these bruises and everything, here also you can see it's under the skin, right? Rectus sheath hematoma. I'll show from the diagram, the anatomical one. Here, here, like that. The accumulation of blood within sheath. Sorry, here. Just think like that. Accumulation of blood within sheath of rectus sheath, sheath of rectus abdominis muscle. So here, that's why we call it rectus sheath hematoma, right? It's accumulation blood in the rectus sheath due to the epigastric artery, right? Epigastric artery cause the bleeding and the accumulation of blood here. Okay, so let's discuss a little bit about the rectus sheath hematoma. If you have any question, confusion, we can just discuss. Okay, and so there's no proper guideline for the rectus sheath hematoma, but we should know these things. Okay, I'll explain these things, and I have a note, my note. Okay, so usually for the rectus sheath hematoma, you have to remember these things. The CT is the gold standard. Okay, the CT is the gold standard one when we are suspecting rectus sheath hematoma. Please remember this is a recall. Okay, a CT. But you have to remember in the cases of children and in the pregnancy, we have to go with ultrasound. The one point you have to remember. Okay, one point you have to, and you have to remember the stage of rectus sheath hematoma, like a type. So what are these types? So type 1 mean this hematoma confined within muscle with no active extravasation. So extravasation mean the leaking. Okay, this hematoma is limited to within the muscle, limited within muscle, and there's a no leakage out of the muscle. So that is type 1. Okay, because when we do the contrast of CT, there's a no leakage we can see here, the type 1. In that case, here we can admit the patients to the observation for the admit hospital to observation and bed rest only. So type 2 case, hematoma confined within muscle with active extravasation of the contrast on CT. In this case, there is a leakage, right? Because active extravasation of the contrast on CT. So, this is leaking, but still within muscle. Here, muscle within muscle, and there's no leaking. In here, also still within muscle, but there's a leaking inside the muscle. Okay, leaking. The active leaking. In this case, admission to hospital, because I already said about the gold standard CT. According to the CT, only we have decided the treatment. So in that case, admission to hospital, bed rest, nil by mouth. So fluid replacement, needle fluid replacement as needed, and analgesia. Okay, in this case also like conservative measures. Then type 3-1. Hematoma with active extravasation of contrast CD that extend beyond the confined muscle. These two still inside the muscle, right? But type 3 mean active extravasation outside the muscle, right? In that case, we have to do the surgery plus blood transfusion. And one more thing, if the patient is unstable in this case, because in this case also there's an active bleeding, right? active. In that case also, patient is unstable, we have to give the blood transfusion. Okay, unstable, but otherwise conservative management. Usually these patients are not unstable. If it is unstable, and the type 3 mean there's a leaking outside the muscle, so we have to do the uh, admission, the everything, the initial management, and the blood transfusion, and we have to do the surgical intervention if needed. Okay, please remember, usually they're asking about this blood transfusion and other things. Okay, I couldn't find the pregnancy related question in the eMedici because everything is not from eMedici, right? So let's discuss this question. I want you to understand the theory. This is all theory from eMedici. Okay, so I have made my note. So 75-year-old present to the emergency department following a motor vehicle accident in which he was front seat passenger. He was wearing his seat belt when the car was involved in the rear end collision. His only complaint of severe right-sided abdominal pain and swelling. He has a medical history of atrial fibrillation and is on warfarin. On examination, he appears unwell with his pulse rate 110, blood pressure 100 by 60, respiratory rate 22, SpO2 94, and the temperature 36.5. There's a tender mass in the right lower quadrant of his abdomen. There's no rebound tenderness or guarding. His initial hemoglobin 95. Repeat hemoglobin 4 hours after 66 with the changes shown in the photograph. Okay. So in that case, what do you think about this patient's stage, the type? What do you think? What do you think about the type? And this classification we call it Berner classification, but you don't have to remember that now. Yeah, the stage. So I'm going to read the answers. Okay, give me 1 minute. Then you have to answer it. Okay, because in this question, it's marked. So answer is reverse anticoagulation and blood transfusion, immediate laparotomy, ultrasound guided drainage, observation and serial hemoglobin measurement, angiographic embolization. In that case, what we should do? Do we remember about the blood transfusion? Yeah, that's the thing you have to remember. And here, another point, because patient is already on warfarin, we already discussed this kind of question, right? Already on warfarin, and the hemoglobin level is decreased, then we have to reverse the anticoagulation as well, right? Yeah. So, I just want to explain from this one, okay? The patient present with the large right rectal sheath hematoma secondary to over anticoagulation and trauma from motor vehicle accident. The image shows the large hematoma within the right rectal sheath, which is a characteristic finding in this condition. And the significant drop in the hemoglobin indicates the ongoing blood loss, and the elevated INR suggests over the anticoagulation. So most appropriate next step is reverse anticoagulation and blood transfusion. This address both underlying cause of the bleeding and resultant anemia. Reversal of anticoagulation typical involvement administration vitamin K, prothrombin complex concentrate, and the blood transfusion is necessary due to the significant drop in hemoglobin and signs of hemodynamical instability. Yeah. And the immediate laparotomy is not indicated as the first line for the rectal sheath hematoma. These hematoma are typical self-limiting and can be managed conservative. Surgery is reserved for the cases where the conservative management failed or there is a signs of abdominal compartment syndrome. And the ultrasound, we are doing drainage here. Then observation and serial hemoglobin measurement alone would be insufficient in this case due to the patient's hemodynamical instability. The significant drop of hemoglobin, This approach might be appropriate for smaller, stable hematomas, the hemodynamically stable patient. After initial stabilization with anticoagulation reversal, the blood transfusion patient should be closely monitored with a serial hemoglobin measurement and repeat imaging if necessary. Most rectal sheath hematoma will resolve with a conservative management, but surgical intervention may be required if bleeding persistent or if there are signs of abdominal compartment syndrome. Okay, the same thing I want to at this question because it has like two things, right? Two scenarios: anticoagulation and patient is on rectal sheath hematoma. This is an extra thing. Please remember, like simply remember, like if you're like comfortable with the types, burner types 1, 2, 3, you can easily think about it. Okay. Yeah, I also wait. Let's discuss about the other things also. Okay, Braxton Hicks contractions are round ligaments as well. Okay. Yeah, it also can be, but the question is incomplete. That's what I also thinking because round ligament, like it's a like sharp stabbing pain, right? Usually felt in the low abdomen, right? And this is usually one-sided one, right? But in here they haven't mentioned about anything, and usually this can be like triggered by sudden movements and coughing as a sneezing and like turning in the bed. Those are the things that can trigger, and this is like quickly settle, right? Short lasting and quickly settle because our patients having like 12 hours, like this pain for 12 hours. Like that's a one point that can think about the rectal sheath hematoma, right? And there's no contractions and no cervical changes, right? Yeah, that's what I also think about this like pain for 12 hours. What do you think is round ligament pain that can last like this long lasting pain? Usually it's like a short term pain, right? What about Braxton Hicks contraction? What do you think? These are the contractions like intermittent irregular uterine contractions. Yeah, that's during the pregnancy, right? Usually in second trimester and more noticeable in third trimester, right? And what are the like symptoms? Irregular and infrequent, mild discomfort or painless. Actually, it's mild discomfort. Anyway, we can exclude this Braxton Hicks contraction. Even I also thinking that we have two options, and the question is not completed, right? Yeah, that's the thing. That's the only option we have got in here, rector sheath hematoma, but we don't know other two options as well, right? That's what we have to think. That's what I'm telling, like, how to know the topic clearly, right? Yeah, in this question, I feel like rectal sheath hematoma still we can go, but we don't know other two options and what is the other parts of the this like stem. That's why I'm thinking. Even I tried to find so much questions, but I couldn't find it because I don't know. I didn't find anything related to this question because everything is not from me, right? Yeah. So we can exclude Braxton Hicks contraction and we have problem in round ligament, but round ligament is like short lasting, right? And settle quickly. Yeah, so you all get the points, right? Just remember, even in exam, you have to like answer according with your question stems and other options, right? Even in the exam you will get a proper question. Even like we are discussing the recalls, even like exam week recalls, and we got like very limited amounts of stems in every question, and in the exam you got like it a good question and good like five options. Sometimes in the recall classes we just marked in the exam week recalls, we just marked in some one answers, but in the exam we got like more clear answers. In that case, if we mark the same thing, we got fail, right? We will fail. That's the thing. You have to think and answer, right? I didn't go with the round ligament because it's a short last. In our patient has 12 hours abdominal pain, and the respiratory tract infection and perceived pain get worse with cough. And yeah, I think still we can think about rectal sheath hematoma because of the pregnancy. The abdomen is stretching like, you know, there's like so much risk factors. Pregnancy is a risk factor, right, for the rectal sheath hematoma. It's the weakening of the this muscles and this rectal sheath, right, due to the stretching of the abdomen and everything. And our patient is 27 weeks pregnant, still can think about like that. It's fine, doctor. You, if you know the how Braxton Hicks contraction occur, the round ligament, how what are the key points, key symptoms, you can still go with the good answer in the exam. Yeah. So let's move to next question. I have added this one to identify the treatment for the rectal sheath hematoma. Okay. How to differentiate blood transfusion and the conservative management. How we go like this. Okay. Let's discuss next question. All women with urge incontinence with mild systole, most appropriate treatment. What do you think? What do you think about this question? Okay. So you all can see how question is like getting trickier and bit harder, right? In the day one, day two, and this is the day three question. So you can see like how they, because if they are giving the same kind of things, because they can't fail us, right? So they're adding more things to stem, and like, the questions are a bit trickier, right? That's why people are telling the last 2 days are trickier. Even, yeah, I was in the situation, the questions were trickier, but if you know like properly theory and everything, it's not a problem, right? Yeah. So, what do you think? You are going with all one and two. We got two answers. Okay, let's discuss about the urge incontinence. So, what is urge incontinence? It is happening in urge incontinence. It's an involuntary leakage. And one more thing, this is the RSCGP guideline for the old woman with the urinary incontinence. It has mentioned everything, I think 20 some pages in there. If you want, you can just go and read it. Okay. Yeah, doctor, questions will get harder because they are not repeating the same question. Harder mean actually in day one, two, we are not getting a full stem, and they are like changing the question. In day one they are giving something else, and the same kind of same stem, but they are changing question, right? But the best part in the last 2 days is, actually last 3 days, the best part is at least you will get some kind of recall. As example, if you are doing exam in Friday, you get this question. Okay, you get this question and it's hard and it's confused. In that case, you are like studying Braxton Hicks contraction and how it's happened. You know how round ligament present and how the pain will appear, and you know how rectal sheath hematoma appear and how you should treat. In that case, if you get a more harder question and trickier, but still you know the theory, right? If you still you know the concept, and In that case, you have time to prepare for your like exam, right? Because you get this kind of recalls, this incomplete questions before your exam. But in day one, day two, they have no idea how the questions are appear. Just they are getting a new kind of question in the exam, right? And if you in this case, you are a bit comfortable with question, right? Yeah, that's the recall. That the recalls are very important, doctors. Yeah, if you can do your recalls by own, if you have a good theory base and everything, you can still do it. But the thing is, you have to cover everything, right? Everything like just go through the topics. That's the recalls. That's the advantage of recalls. Otherwise, there's no point of doing recalls. The main thing is you will be like getting comfortable with the question, and you study this question during the exam week, the theory. Then then you can like answer any question from the theory because you know A to Z theory, right? Yeah, that's how you should prepare in the last day. So, in the bladder training and vaginal pressure, we got two answers from different doctors. So we all know urge. There are different types of incontinence: urge, stressed, mixed. There are so many, not so many. There are different types. So here the urge one is involuntary leakage due to the detrous muscle, right? Detrous muscle overreactivity. So detrusor muscle overreactivity, the patient can have the involuntary leakage of urine. Patient can't hold the urine, right? A strong urge to void that is difficult to differ due to these detrusor muscle overreactivity. So clinical features: urgency, frequency, nocturia, large volume urine loss, often worsen with the running in water, cold, or arriving home. So risk factors: increased age. In our case also, our patient is old one, and the neurological disease such as stroke, Parkinson disease, multiple sclerosis, usual neurological diseases can affect diabetes, urinary tract infection, bladder irritants such as caffeine, postmenopausal state. So examination: abdominal examination, exam for bladder distension, pelvic exam to assess the prolapses, neurological screen if indicated. So what are the investigation? So anyway, we have to rule out the urine analysis, right? First, because due to the UTI also, patient can occur some incontinence, right? Not the urge one, but incontinence. In that case, we have to do the urine analysis as the first thing. Then we can advise patient to make a bladder diary, pause void residual, and urodynamic. And this is not the first line. Okay. So I'll explain this investigation order from the question. Okay. So here, okay, let's do this question and come back. So 79-year-old man present to the GP clinic with 3 months history of urinary urgency, frequency, and occasional urge incontinence. He reports having to rush to the toilet up for 6 months during the day and 3 times at night to urinate. He has experienced several episodes of incontinence before reaching the toilet. His medical history include type 2 diabetes, chronic kidney disease, osteoarthritis of both knees, and a previous transient ischemic attack. His medication include metformin, paracetamol, and he lives independently and walk with a stick. On examination, he appear well within normal limits. Digital rectal examinations reveal smooth, non-tender prostate of normal size. Neurological examination of the lower limb is normal. Which one of the following most appropriate initial investigation? So, what do you think? What about other doctors? Okay, what about other doctors? Mm-hmm. Okay, you are going with 3 24-hour pad test. Okay, let's check the answer. Okay, I'll explain. Here, the answer is post void residual volume measurement. Okay, so even I was doing my preparation. I was also going with something else. Then I did the eMedici, then I got the point. So this patient presented symptoms of suggestive overreactive bladder syndrome, that mean urge incontinence characteristic by frequency, urgency, nocturia, and yeah. Before initiating a specific treatment, it is essential to exclude underlying cause, particularly in older adults. So post void residual volume measurement is the most appropriate initial investigation. Why? It is non-invasive, easily performed using bladder ultrasound, and help to exclude significant urinary retention which may be contributing to the symptoms. This is particularly important to older men where bladder outlet obstruction may be present despite a normal feeling prostate. Okay, so in old people, just think about post void residual volume measurement. Okay, not only for the older man is suspecting this prostate thing, you have to like you have to exclude the retention as well, right, before treating the treatment. So why not urodynamic studies are specialized tests that may be helpful in complex cases or before surgical intervention, but they are not the first line investigation. So, what is 24-hour pad test? Can quantify urine loss but does not help to identify the underlying cause of the symptom. It may useful to monitor the treatment response but not the most appropriate initial investigation. So, here the post-voidal residual measurement is the first line investigation for urinary symptoms in older adults to exclude the urinary retention. Right? And urge incontinence in older adults require exclude underlying cause including infection, retention, and neurological condition before specific therapy. Right? This is not important in today's topic, but please remember. Okay, so urine analysis and urodynamic studies. No, it's not urodynamic study. Post void residual volume measurement. Okay. Here they are asking most appropriate initial. Okay, in that case, we have to go with post-voidal residual volume. Otherwise, we have to check for the urine analysis to exclude the infections. Okay, like that you have to answer. Here, I have added some. No, I have. Okay, so let's discuss about our this thing. So, urine analysis culture to exclude UTI, then we can advise patient to make a bladder diary and post-void residual. So remember this post-void residual, especially in the older people with urge incontinence, we have to do the urine analysis to exclude the infection, and we have to exclude the urinary retention as well, right? So in that case, we have to do post void residual measurement. This is a very non-invasive one. Just do a ultrasound. Okay, in that case, yeah. So how we manage these patients? So first line is a bladder training, right? Pelvic floor muscle training or lifestyle measurements like reduce caffeine, time voiding, optimization, like that. So bladder training, pelvic floor muscle training, and lifestyle measures. So second line, if these first line are not working, then we have to think about the antimuscarinic like oxybutylene, solifenacine, and the beta 3 agonist like mirabegron. This is usually useful in the older patient with their side effects of oxybutylin. Okay, this antimuscarinic, anticholinergics, patient with history of falls, like that. If you can do some question for the chin continence, you will found the mirror background as an answer in that scenario. I can't add everything in here, so in that's why I'm just like quickly explaining the topic. Okay. So in our question, they are mentioned about all women with urge incontinence with mild cystocele. So most appropriate treatment in that case, there's a mild cystocele, right? So in mild cystocele, we don't have to treat, right? In mild cases. So in that case, we can go with the bladder drain. Let's discuss a little bit about the vaginal prolapse. So there are different types of prolapses. So cystocele. Cystocele mean here what is happening in cystocele. Anterior vaginal wall, anterior vaginal wall prolapse, right? What is rectocele? Posterior vaginal wall prolapse, and the uterine prolapse. That means sensation of something coming down, like a pelvic pressure due to the uterine is going to the vagina, right? Like that, that enterocele, pelvic pressure, deep vaginal discomfort. So mainly the asking about the cystocele and rectocele. So how cystocele present? Vaginal bulge, stress, incontinence, incomplete empty. And the first line, pelvic floor muscle training with the symptomatic and moderate. The first line is the conservative, right? Like pelvic floor muscle training. And if this is not working or patient needs like moderate situation, we can go with the vaginal ring or pessary plus or minus vaginal estrogen. It's depend on the situation. And the severe case, we have to do the surgery, right? We have to do the surgery. In the rectocele, we have to do the constipation, pelvic floor exercises, and the patient is symptomatic and patient is moderate severity, we can do the vaginal pessary. And the severe cases, we have to do the surgery. Just remember, actually, in first line, as a first line thing, as a mild cases, we are not we are not doing some interventions. In that case, just we can do the like exercise. We can advise patient to do some exercise and treat the underlying other symptoms like that. If it is moderate, then we can think about vaginal pessary. That okay. Severe, we have to go with surgery. So in our case, patient is mainly having the urge incontinence with mild systole. So in that case, we can go with the bladder training, right? They are mainly focusing about urge incontinence and mild cystocele. So I think we can go with bladder training, right? Agreed, right? What do you think, doctors? Please. Uh, if there's a retention can lead to pressure and urge incontinence. What about are you asking about the retention, right? Yeah, doctor, it can urinary retention can lead the pressure and make the urge incontinence, right? That's correct. Retention also can cause the pressure and make the incontinence. So we just discuss, like quickly discuss about the everything. Okay, so let's move to our next question. Yeah. So our next question is women urinating 10 times, the same thing. The woman urinating 10 times daily with urge incontinence as well. No UTI. Then initial investigation, bladder diary, morning fasting glucose, urodynamic studies. What do you think? Yeah, in that case, in that case, we can go with the initial in urine analysis, then blood chemistry. Yeah, initial investigation can go with that. If they ask in most appropriate one, then you have to think about the post void residual volume measurement, okay, to exclude the retention. Okay, so let's discuss our next question. So, pregnant woman, 38 week, right upper quadrant pain, blood.
তোর ওয়াইফকে তো বলছিলাম কাপ দেখার বিষয়ে ওয়াইফ নাই রেজিস্টার্ডে ছিল না শুনি তো ওইবারে ও শুনে না
Doctor, are you talking with me? Yeah. Okay, no, I think I mistakenly on the mic, so it's fine. So, what do you think about this question, doctors? Pregnant woman, 38 week, right upper quadrant pain, blood pressure 140 by 85, fever. What about other doctors? Preeclampsia, cholecystitis, pyelonephritis. Mm. This also very tricky, right? This question. Mm-hmm. So, what is the blood pressure criteria for preeclampsia? What is the blood pressure criteria? What is it? Mm-hmm. Okay. So, what about other doctors? Mm. Okay. So let's discuss about the different how pyelonephritis is appear, like what are the symptoms in pregnancy. Pyelonephritis, how these patients appear. How? Who can tell me? Okay, so let's discuss one by one, okay? Because the question is not very clear, right? So I know it's not pyelonephritis because they have mentioned right upper quadrant pain, right? So do you remember we have discussed one question about the HELP syndrome, right? HELP syndrome also. Yeah, so I think this kind of same, but we don't know. Let's check one by one, okay? Because they again like something related. This is out anyway. So cholecystitis, we have the confusion between cholecystitis and preeclampsia, right? So we don't know urine protein trace mean how much urine in the protein, right? We don't know, right? We don't know the proteinuria level, and there's a ketone plus and the fever. So the preeclampsia patient present with fever. What do you think? Do they have fever? The preeclampsia patient, do they have fever? Yeah, that's the problem. I also thinking the preeclampsia, the other things are like not preeclampsia complication, HELP syndrome. Other things are like little bit like we can think about it, but the fever. What do you think about fever? Okay, yeah, yeah. You have to think about each and every symptoms, right? So fever, it is like related with the cholecystitis, right? And the right upper quadrant pain, fever related with the cholecystitis. Urine protein, we don't know how much, right? And the ketones in the pregnancy sometimes can be plus due to the high dehydration, right? Those kind of thing, like only +1. Yeah, yeah. Yeah, doctor, due to acute infection and the patient is pregnant, right? Due to dehydration, there are so many things like we can think about these protein trace because they haven't mentioned about like 3 plus 4 plus, like they haven't mentioned anything about like severe protein, just urine protein trace and ketone plus. This can be ketone plus just happening during the dehydration and infections like that, okay? So in that case, due to fever and right upper quadrant pain, they have more prone to cholecystitis. If we don't have fever, just we can think about the preeclampsia, right? And the preeclampsia like more than 180 and 90, right? Not 85. Yeah, with high proteinuria and at least one of like severe headache, visual disturbances, severe pain just below the rib or vomiting. Okay, I'll show how. I don't know, is it available in the say help? You know, now the say health has removed so much the guidelines from their website because previously usually they are having this kind of guidelines, and I was recently searching something, I can't remember the topic. They have like just removed it, but I have saved in my notes, but I don't know why they have removed so much guidelines from SA Health. Everything is business. Yeah, doctor. Yeah. Yeah, I think they have removed, I don't know why. So here you can read about the preeclampsia here and all other hypertensive diseases. In here they have good criteria. Mm. Yeah, here. So this is the definition. So preeclampsia, a multiple system disorder characteristic by hypertension and involvement of one or more other organ system and or the fetus, okay, or system or the fetus. The proteinuria is most common recognized in additional feature after hypertension, not mandatory for clinical diagnosis. Yeah. And the usually after 20 weeks, this criteria is present in our patient. Yeah, but they haven't mentioned anything about the fever, right? Yeah, they have oliguria and everything they have mentioned. This is the complication, the renal one, hematological liver. You can read it. Yeah, doctor. Yeah. Yeah. So the thing is, I think, s I think from here the cholecystitis is like have like make more sense than preeclampsia, right? What do you think? What do you think? But it's fine, right? In the exam, you will get a proper questions from preeclampsia and the cholecystitis. We already discussed about the pregnant case with cholecystitis treatment. So, what is the treatment for cholecystitis during the pregnancy? Who can tell me? Okay, yeah. What do you think about, not think, you have to answer like the answer should be like sudden, okay? What is the treatment for acute cholecystitis during the pregnancy? I have shown. Mm-hmm. What about other doctors? Because I have showed the example as well. Mhm. Okay, I'll show it again here. In that case, okay, let's check this question again for the symptoms. Okay, here 27-year-old woman G1P0 presented to the emergency department, 24-hour history of increasing right upper colon pain associated with nausea. She's normally in good health with no significant medical or surgical history, currently 30-week pregnant. Examination, she looks well, blood pressure 110/70, pulse 90, temperature 37.6. She's tender immediately under the right costal margin. The rest of the abdominal soft and find inconsistent with third-week pregnancy. Ultrasound confirmed the presence of gallstone in a thick wall gallbladder. So how gallbladder in the cholecystitis? What are the ultrasound findings? I have Oh, okay. So what are the ultrasound finding in acute cholecystitis? So what are the ultrasound? Okay, more. Need more options. Need more answers. Do you remember? Yeah, you are correct, doctor. Yeah. Ye- Yeah, doctor. Yeah, nice. You all have revived, right? So no problem. Yeah, thick gallbladder and presence of gallstones. So acute cholecystitis in this case, admit for semi-urgent laparoscopic cholecystectomy. Okay, we have discussed we can do the laparoscopic. So yeah, can do the laparoscopy, right? Semi-urgent. Yeah, same thing to release the symptoms, right? So let's discuss like quickly how pyelonephritis present: fever and chill, flank pain, more than right upper colon pain in this question. Okay, dysuria, frequency may not be present, nausea, vomiting, costoverbal angle, tenderness can be seen. So urine, pyuria, bacteriuria, protein may be trace, ketone may be appear due to dehydration. And the cholecystitis, progesterone causes gallbladder stasis, increase the risk of gallstones, especially in late pregnancy. We know this theory. So typical presentation: right upper quadrant pain, fever, nausea, vomiting. Pain may radiate to the right shoulder. Murphy sign may be positive, and the blood pressure may be mildly elevated due to the pain or stress. Urine protein can be incidental. Ketone often positive due to the poor oral intake. So, and the preeclampsia, just quickly discussing because we have so much to discuss. So, preeclampsia, hypertension 140, more than or equal to 140 by 90, with significant other organ involvement. I have showed the picture. And the, yeah, right upper quadrant or epigastric pain due to the liver involvement, usually in HELP syndrome, headache, visual symptoms, nausea, vomiting may be occur. So, like considering this fever part, we can go with the cholecystitis, but we don't know the proper question, right? So please make sure to make sure about the preeclampsia, pyelonephritis, and cholecystitis, how present in the pregnancy, and what are the treatment options. So if they ask about the diagnosis in day one, they can ask treatment in day two. Then day three, they can ask about diagnosis like that. Okay, and the questions can be more complicated with more details. Please do eMedici questions. Okay. Then All women entered to your hospital claiming herself to be some sorceress and calling out loudly that all hospital workers are fraud and she will kill them all. What to do next? Call security, offer her tea and biscuit, immediate interview. Yeah. In this case, there's a immediate harm, right? Immediate threaten. So in that case, we have to first call the security, right? Because she's yelling that she will kill them. She will kill all the hospital members. So in that case, we can't offer her tea and biscuit, right? We can't, yeah, offer her tea and biscuit. She will kill us, right? In that case, first we have to think about our security first, then call security, then later after assessing and after immediate review and after return according to the mental health act, then after calming down we can offer her tea and biscuit. But in the first, if we offer tea and biscuit, we are dead, right? So don't forget it, okay? Yeah. Yeah, doctor. No, for de-escalation, no, I don't think. Okay. Yeah, these patients are not de-escalate with the tea and biscuit. Okay. So here we have to ensure our safety first. So we have to call the security, de-escalation verbally if possible. Then we have to assess the patient. But the first of all is we have to call the security, right? Then we have to think about the under mental health action. We have to do the other interventions like involuntary treatment, right? Because the patient is like, you know, he's like threatening others. In that case, we have to use this mental health act to involuntary treatment. Yeah. For first of all, they're asking what to do next, so call the security, right? Yeah, that's the question. So we will take 10 minutes break, then we will come back, okay? Please have some coffee or tea. You know, what do you think about this file? What do you think about this day 3 questions? What is your opinion? What is your opinion about day 3 file? Yeah, yeah, that's the thing. You have to understand. It's always easy as usual. Yeah, very easy, doctor. Okay. So let's meet. My time is 7:54. We will meet after like 7:55, like 8:05. Okay. Okay. So yeah, yeah, done with this question. Okay. So exact image was given and asked for the diagnosis. What do you think? Form HPV, HSV. What do you think? Type your answers in the chat. Yeah. So what is the synonyms for form for X? You should know. What do you think? Yeah, you are correct. Okay, so let's discuss about the form for X. Okay. So what is dyshydrotic eczema? This is the another name we call for the form for X. Okay. So in here, what is here? The same kind of picture, right? Here, right? It's like a small blister kind of thing. Like, okay. Yeah. Okay, so let's discuss bit about it. It is a chronic itchy. You have to remember symptoms: itchy, chronic recurrent, often symmetric eruption of the palms of hand, fingers, and soles of the feet. This is characteristic by small, deep-seated 1 to 2 millimeter fluid-filled vesicles on these side, which resolves after several weeks with scaling. So you should know how this present and what type of disease is that. Okay, and the locations. And here, okay, this is the pictures you should know. Okay, yeah, this is from the Dermanet. So, what caused these form filix? These form filix caused by this is the cause of these form filix is not known. It is not related to occlusion of sweat glands as was first thought when the disease was recognized over 100 years ago. So, atopy. The evidence is mixed with some reporting as the risk and others not. With contact dermatitis, fungal infection, photoinduction, immunoglobulin therapy, hyper hyperhidrosis, like these are the can be related with this, but we don't know the cause is not known. Okay. So what are the clinical features? The vesicles are small, 1 to 2 millimeter. We know often symmetrical, not associated with erythema. And they do not occur elsewhere on the body. Vesicles may, uh, yeah, calls into the last blisters. It is extremely itchy. Vesicles common resolves after 2 to 3 weeks with peeling. Vesicles can occur in other types of hand dermatitis. So, how these from Felix diagnose? This is the clinical diagnose of the history of clinical appearance. And we have to exclude other things as well because we will discuss it. And herpetic whitlow also kind of same. And the what is other thing we have to exclude? What is the same kind of thing? What do you think? Okay, herpetic whitlow. Then what about other thing? Other. Do you remember something like this? Small white papules. Molluscum contagiosum, like it also kind of same like this. So we have to exclude these other pathologies as well. Yeah. So here these are the differential diagnoses we already discussed. So what is the treatment? Here the avoid aggravating factors where it's possible. Potassium permanganate salts may be used in acute phase. And the specific treatment topical steroid. Remember topical steroid, tractarimus, pimecrolimus. Okay, these are the phototherapy, systemic therapy like antihistamine because these are very itchy. So there's no specific treatment, just according to the symptoms we can treat. Usually in the example they are asking, sorry, in the exam they are asking us to differentiate and identify the diagnosis. Okay, so for that you should know the clinical presentation and everything, like different other differentiation thing. So here, according to this photo, we can go with the form follics. But how the HPV and HSV present? How these two present? So in here, herpetic whitlow, it also has the same kind of thing, right? Here, the vesicles. Yeah, but the clinical symptoms and other things can be different, right? This herpetic whitlow is painful. These are painful viral cutaneous infections that usually affect the distal fingers or thumbs and occasionally toes. It caused by herpes simplex type 1 or type 2 and can be vesicular or pustular in nature. Please remember, okay, these symptoms. Here you all can see both are like kind of similar though, right? Here. So usually, but if they are giving about the herpetic whitlow, usually these are painful vesicle, right? Painful, and this can cause the ulcers. We call it ulcerative one. You should remember these are painful vesicles. Okay, usually often on fingers. Then what about these pompholyx? These are itchy vesicles. Okay, usually symmetrical. Right? Remember these things. Then in the question they have given HPV what as well. So how these are present? We all it's like a cauliflower, right? Here, here the filiform warts because there are different types of warts. So let's discuss about the viral warts in the hand. Okay, so viral warts is a very common benign lesion caused by HPV. Benign, it can classified as a cutaneous and mucosal as the HPV are quite distinct. Genital warts, we all know there are different types of warts in HPV. Yeah, the cutaneous warts also called the verruca or papilloma and warty-looking lesion, and cause may be described as verrucous or papillomatous. Just remember these other names for HPV cutaneous warts. Okay, these appear like this, different, right? Yeah. So we differentiate all of three, and you have to differentiate the molluscum contagiosum and as well. So how the molluscum contagiosum, they small papules present, the white color papules present. What are the features of these papules? Please tell me, you should know how these things are present. Type in the chat, umbilicated. Yes. What about other features? I'll show the pictures. Here, you can see like whitey papules, right? So these are small dome-shaped papule, right? Central with central umbilication. Let's check question. More pictures here. You can see the dome shape, right? With the centrally umbilicated. And these are not painful. It's usually painless, right? And there's no vesicles or no pain in here. So what is the treatment for this? So what is the treatment? Tell me treatment and school exclusion criteria for molluscum contagious. Tell me. You should know. Type in the chat. It's a very common question in AMC. The molluscum contagiosum. Okay. So pediatric rashes. Yes, no exclusion. So treatment. So there is a no treatment as well. Okay. So please remember. Okay. Please remember. Yeah. Okay. Yeah. Okay. Let's go back to our session. So you all know how to identify. Just remember, like, okay, these form Felix like itchy, symmetrical vesicles. For HPV, they are painful group of vesicles. Usually it's unilateral. Okay, usually it can be bilateral. And the molluscum contagiosum, we already discussed, umbilicated, dome shape, papules. Then HPV, these are different, cauliflower shape. Yeah, this is how it was. So next question is, the day 3, we got so much derma questions. So this image was given to us for the diagnosis. So here, what do you think? Pemphigus foliaceus, melanoma, seborrheic keratosis. What do you think? Pemphigus foliaceus. So how it present? Who can tell me? Tell me. Mhm. Okay. Let's check. Yeah, you just answered. Okay. How it is it? Okay, let's check one by one. So, pemphigus foliaceae. So, how it is? What is that? It's an autoimmune blistering disease, right? Antibodies against the desmoglein 1. So it's superficial, fragile blisters that rupture easily and crusted and scaly erosions. No mucosal involvement. Please remember this is just superficial. Okay, please remember here. And Nikolsky sign positive. So what is a Nikolsky sign? That mean when the gentle lateral pressure on the normal appearing skin that can cause epidermis to shear off. Okay, I'll show Kolsky sign. Yeah, yeah, the same thing. Yeah, the top layer of skin can be removed with the lateral rubbing, leave the moist base. Same thing. Okay. Yeah. It is positive in here. Okay, where's my file? Yeah. And treated with a systemic corticosteroid with or without immunosuppressant. This is the dermanate picture for the pemphigus foliaceae. Okay, so this is how it appears. This is an autoimmune disease. So, how the seborrheic keratosis appear? Who can tell me? There's a specific one. What kind of appear? The waxy lesions, right? Waxy. You have to remember, seborrheic keratosis is a benign epidermal tumor, common in older adults, stuck on like waxy appearance and well demarcated brown or black lesions. These are asymptomatic. These are not malignant potential. Okay, I'll show. How is your like derma knowledge? Is it good? What do you think? Okay, second. Can't search. I don't know, doctors. Sometimes this therapeutic guideline and everything is like, okay, now got it. Okay, I'll show. Yeah, you should remember. Really, but derma is not very hard. You should know the like derma is interesting, right? No? Okay, please. Okay, so you have to remember this. Okay, this is the appearance of the seborrheic keratosis. We call it solar keratosis as well. Yeah. Mm. Yeah. Here, waxy appearance, right? Here, you all can see waxy appearance. These are the pictures you can see in the seborrheic keratosis. Okay. Yeah. So, waxy or what is stuck appearance. It's a very benign, so you don't have to worry. Okay, so let's go back to our topic. I just want to show the picture. Okay. Drama is bad. You have to remember those, just the picture, then treatment, and like, uh, do you want my highlighted PDFs for the dermatology? I think I have shared, but if you want, I can share it again in the group. I have like make everything from TG. I have downloaded the TG PDF and write and added the emergency questions and everything. Yeah, sure. But I think it's kind of messy because I have like marked something different colors and everything, but still you can use it, right? Okay. So this is how seborrheic keratosis appear like waxy lesions. Okay, please remember, just go through the seborrheic keratosis topic as well. Okay, so we don't have much time to like discuss each and every topic. I'm just having to I just have added for further reference. I think this picture is like pemphigus foliaceus, right? Yeah. Okay. So if I didn't share, please just remind me, okay? Because I'm getting so much messages and sometimes my brain is not working. I can't reply any of that. Okay. So the similar picture was given, however, the lesion was black. The lesion was black. Okay, here's the lesion, and this is black. Anyway, this is in the eye, right? So in that case, we have to refer for the plastic surgery. We are not doing excision in this. The sensitive area like eye, right? So you all agreed we have to refer for the plastic surgery, right? Okay, so next question. Vaginal spotting and pain, nausea and vomiting on 21st day of her cycle, asking what is most important to exclude: ectopic pregnancy, ovarian torsion, cyst rupture. What do you think? Type your answers in the chat. Ovarian torsion, okay. What about other doctors? What are the clinical presentation of ovarian torsion? What is the clinical presentation of the ovarian torsion? Mm-hmm. Mm-hmm. What about other symptoms, like how the pain and everything appear? Is there any bleeding in ovarian torsion? Is there any vaginal spot in? Mm-hmm. Okay. Yeah, free fluid maybe because we have discussed. No, we haven't discussed about the torsion. We have discussed the cyst rupture, ovarian cyst rupture. Mm-hmm. Okay, so yeah, here there's no vaginal spotting. Okay, the patient is vomiting on 21st day of her cycle. Ask it most important. Okay, so let's do this question. Then we will come back. Okay. 16-year-old girl present to the emergency department with 12-hour history of nausea and lower abdominal pain associated with urinary frequency. She has regular 28-day menstrual cycle and her last period was just over 4 weeks ago. She does not take any regular medications. On examination, she appears unwell. Her pulse rate is 90, blood pressure 112, by 78, respiratory 18, SpO2 98, temperature 37.6. She's tender in the right iliac fossa. So, which one of the following most appropriate next investigation? Urinary beta HCG, full blood count, transvaginal ultrasound, serum beta HCG, urine analysis. What do you think? Okay, so everyone is going to urinary beta HCG. Let's check the answer. Okay. In this case, okay, in this case, present present a 16-year-old girl with symptoms that could be consistent with several conditions, including ectopic pregnancy, urinary tract infection, appendicitis, or ovarian pathology. Given her age and sexual maturity, pregnancy related complications must be considered and ruled out first. So, urinary beta CG is the most appropriate next investigation. It is a rapid, non invasive, and highly sensitive test that can quickly determine if the patient is pregnant. This information is crucial for the guiding further management and interventions. A positive result would be raised suspicious for ectopic pregnancy given in the patient's symptoms and would be prompt immediate further evaluation. Okay. So ectopic pregnancy should always be considered in women of childbearing age who present with sudden onset low abdominal pain. Urinary beta CG test rapid, sensitive, and non-invasive first-line investigation for suspected pregnancy in emergency setting. Clinical assessment and pregnancy testing should precede imaging study in younger women with abdominal pain. So now, what do you think about our question? They're asking what is most important to exclude ectopic pregnancy, ovarian torsion, cyst rupture. What do you think? You got the point, right? Do I need to explain more? Right? Yeah. Yeah, doctors, that's I want to explain. It was very hard. I was searching so much questions to like, yeah, to find the same kind of thing. Okay, here our patient is 21 day of a cycle. So patient is menstruating, a girl, so it's in reproductive age, right? Yeah, and here in the reproductive age with menstruating, in this case, we have to first exclude the ectopic pregnancy. So, and you have to remember if they ask about what is exclude in this case, as example, ectopic pregnancy, then next day they can ask what is the most initial investigation to exclude like ectopic. They are not asking like that. They can ask like this. Okay, next most appropriate investigation like that. That's why I have added this question. Right? You all get the point. Do I need to explain more about it? Just you all understand it.